Let me set the scene for you. You're 74 years old, feeling wonderful, sleeping soundly, your energy levels are solid, and you're staying active with things you love. You head in for your yearly checkup, nothing out of the ordinary. Your doctor scans your file and says, "Let's run a couple of tests just to be thorough." A month and a half later, you find yourself in a surgeon's waiting room. Not because you were ill, but because those just to be thorough tests uncovered something. And that discovery triggered a series of events your 74-year-old body wasn't prepared to handle. Suddenly, the peaceful life you were enjoying looks completely different. That precise scenario unfolds more frequently than the healthcare system likes to acknowledge, and the evidence behind it warrants a real discussion. I'm Dr. Emily Carter, and this channel focuses on a single mission: helping adults over 60 make sense of what medical research truly shows about their health, explained in everyday terms. What I'm about to share isn't pulled from one textbook. It comes from years spent reviewing medical studies and closely observing what the evidence reveals when the healthcare system operates on default settings. Here's a truth most physicians won't state plainly during a rushed 15-minute visit. Once you pass 70, several of the most common routine medical exams can do more damage than good. Not because medicine is flawed, but because the risk versus benefit calculation shifts significantly with age, and no one is actually running those numbers with you in the room. Today I'm guiding you through 5 particular medical exams I would personally think twice about after turning 70. I'll explain why the calculation shifts, share what I've witnessed happen to actual patients, and by the end, I'll hand you a list of questions that will completely reshape how your next doctor's visit unfolds. Stick around for all 5, because the third one has genuinely shocked people the first time they hear it, and the 5th is one most people never learn about until it's too late. Before diving in, I'd love to know, where are you tuning in from today? Share your city or country in the comments below. I read every single one, and it truly helps me understand who makes up this community. Now let's begin. Before covering the 5 exams, I need to introduce one idea, because without grasping it, nothing else I say will click. I call it the longevity lens. At age 50, preventive screening works wonderfully. You catch a problem early, treat it, and potentially gain another 3 decades of healthy living. The trade-off is worthwhile. The logic holds up cleanly. But here's what shifts after 70. 3 specific things. First, many conditions caught through routine screening in older adults will never actually cause harm. They progress slowly, produce no symptoms, and you'll likely outlive them entirely. Yet once something appears on a report, medicine doesn't offer a leave it alone and monitor option. It defaults to treatment. Second, your body's capacity to handle intervention declines as you age. A surgery a 55-year-old recovers from within 2 weeks might mean months of rehabilitation, complications, lost independence, or worse for a 78-year-old. Third, there's what's known as the cascade effect. A minor abnormality shows up on one test. That prompts a follow-up scan. The scan suggests a biopsy. The biopsy leads to a procedure. The procedure results in a complication. Before long, someone who arrived feeling completely fine is now caught in a medical crisis, all triggered by a test they never actually needed. That's the longevity lens. Hold on to that concept as we move through each point. Before we continue, share your name and where you're watching from. I go through every comment and genuinely want to know who I'm connecting with and supporting here. Exam number 1, routine colonoscopy, past age 75. Let me introduce you to Dorothy. She was 77, a retired librarian living in rural Tennessee. She'd undergone 2 colonoscopies previously in her 50s and 60s, both entirely clear, no polyps, no family history of colon cancer, no symptoms at all. But her new primary care physician reviewed her records and told her she was due for another one. Dorothy looked into it. She had reservations but didn't want to come across as uncooperative, so she went ahead. The prep, the liquid solution you drink the night before to clear your bowels, hit her kidneys hard. By morning, she was disoriented, lightheaded, and could barely stand. Her daughter rushed her to the emergency room before she ever reached the procedure. She was severely dehydrated, and her electrolyte levels had dropped to dangerously low levels, putting her heart at risk. Dorothy spent 4 days hospitalized. She never actually had the colonoscopy, and ironically, she never needed it. The United States Preventive Services Task Force, the leading authority that establishes screening guidelines nationwide, officially advises against routine colonoscopy screening for average risk adults over 75. The evidence is unambiguous. Past 75, if you're symptom-free, have no family history, and your previous scopes were clean, the risks start outweighing the benefits, and those risks are genuine. Bowel perforation, an actual tear in the colon, happens in roughly 1 out of every 500 colonoscopies. For a younger patient, that's a manageable surgical setback. For a 77-year-old, it could mean emergency surgery, a colostomy bag, prolonged hospitalization, and a recovery that permanently alters quality of life. Meanwhile, the colon cancers most commonly discovered in symptom-free older adults tend to progress slowly enough that in many cases, they'd never cause trouble within a person's remaining years. What should you do instead? Ask your doctor about a non-invasive, stool-based test such as Cologuard or an annual FIT test. These can catch genuine warning signs without the procedural dangers. And if symptoms do appear, blood in your stool, unexplained shifts in bowel habits, that changes everything. See your doctor right away. Exam number 2, aggressive PSA prostate testing and yearly mammograms for low-risk individuals. I want to be very careful here because this subject requires nuance. I'm not suggesting you skip cancer screening altogether. Cancer screening has saved countless lives and could absolutely save yours. What I am pointing out is this. Past 75, aggressive cancer screening in average risk, symptom-free individuals carries a significant overdiagnosis issue. An overdiagnosis directly leads to overtreatment. Here's what overdiagnosis means, simply put. Modern imaging is so precise, it can detect cancers that are biologically essentially dormant. Tiny, slow-growing tumors that, if left untouched, would never spread, never produce symptoms, and never shorten your lifespan. You die with them, not because of them. But once a radiologist writes malignancy on a report, the clinical process kicks into gear. Biopsies, specialist referrals, treatment decisions, all move forward regardless of whether that cancer actually threatens you. Take Richard's situation, a 79-year-old retired mechanic from Georgia, sharp, independent, still out fishing on weekends. His routine PSA came back mildly elevated. A biopsy confirmed a low-grade, slow-progressing prostate cancer. His urologist suggested radiation therapy. Richard followed the recommendation. Within a year, he was struggling with chronic exhaustion, urinary complications, and a noticeably diminished quality of life. Stories like his appear repeatedly throughout medical literature. Men who, in hindsight, wish they'd understood their cancer was the type someone their age would almost certainly live with, not die from. That understanding, had it arrived sooner, might have changed the entire outcome. Research published in the New England Journal of Medicine found that a considerable share of cancers identified through mammography in women over 70 were clinically insignificant, meaning treatment provided no survival advantage, only side effects. What should you do instead? Have a candid discussion with your doctor about your individual risk profile. If you have family history, genetic markers, or symptoms, get screened. If you're average risk with no symptoms, ask directly, if we discover something, what are the realistic treatment paths for someone my age, and what would we likely recommend? That single question often transforms the entire conversation. If you're still with me and finding value in this, drop the number 2 in the comments. It lets me know you're engaged and getting something useful from this. Exam number 3, routine cardiac stress testing without symptoms. This one catches people off guard because it sounds so reasonable. Your doctor says you're 72, let's just confirm your heart's in good shape. You get on a treadmill or receive medication that temporarily puts stress on your heart while they monitor your response. Sounds harmless, sounds prudent. Here's the catch. Cardiac stress tests in symptom-free individuals have false positive rates that can hit 40% or higher in certain groups. That means nearly half the time, the test signals a problem when your heart is completely fine. But medicine can't simply dismiss an abnormal result. That false alarm sets off the next phase, a cardiac catheterization. This involves threading a thin tube through your blood vessels, typically via your wrist or groin, straight into your heart. It's a serious procedure. Risks include bleeding, vessel injury, arrhythmia, and in rare instances, it can actually trigger the heart attack or stroke it was meant to prevent. And here's where it gets even more counterintuitive. If the catheterization reveals a partial blockage, which is remarkably common in adults over 70, many without any symptoms, you might end up receiving a cardiac stent. Multiple major clinical trials, including the widely referenced ischemia trial, discovered that stenting in patients with stable coronary artery disease didn't reduce heart attacks or extend lifespan compared to medication and lifestyle adjustments alone. I'll repeat that. The stent offered no advantage over medication, yet it carried its own real risks, followed by a lifetime on blood thinners with their own bleeding hazards. So you've gone from feeling perfectly healthy to a routine test, a false alarm, a catheterization, a stent, blood thinners, and ongoing monitoring, and statistically, you're no better off than someone who simply managed things with medication and a 30-minute daily walk. What should you do instead? If you experience no chest pain, no unexplained breathlessness, no dizziness during physical activity, routine stress testing is searching for issues in a population where those issues are common, but intervention doesn't necessarily help. Discuss optimizing your risk factors with your doctor instead. Blood pressure, cholesterol, blood sugar, activity levels, sleep quality. That's where real progress happens. Exam number 4, routine bone density DEXA screening paired with automatic medication. This one tends to make people uneasy when I bring it up, because osteoporosis is a genuine concern, and falls can be devastating for older adults. So let me be precise, I'm not disputing the reality of age-related bone loss. I'm questioning the automatic pathway that often follows a DEXA scan result in patients over 75. A DEXA scan reveals low bone density. Your doctor prescribes a bisphosphonate, medications like alendronate or risdronate. You take them for years, assuming you're protected. But here's what's frequently left unsaid. Long-term bisphosphonate use has been linked to a rare but serious condition called atypical femoral fractures, spontaneous stress fractures, in the thigh bone, the very bone the medication was supposed to protect. These fractures can be severe and often require surgery. Additionally, these drugs are associated with osteonecrosis of the jaw, a painful and difficult to treat form of jawbone deterioration. Meanwhile, the most effective way to prevent fractures in older adults, hands down, isn't medication, it's fall prevention. That means balance training. Research shows Tai Chi alone can cut fall risk by nearly 50%, along with removing tripping hazards at home, installing grab bars, reviewing medications for dizziness-inducing side effects, getting regular vision checkups, and maintaining sufficient protein and vitamin D intake. These strategies lower fracture risk more meaningfully than any medication with zero side effects. I'm not saying medication is never appropriate for bone health. Plenty of patients genuinely need it. Those who've already fractured, those with very low bone density scores, those with specific risk factors. But a routine DEXA scan, automatically leading to long-term medication for an active 74-year-old who's never broken a bone and is otherwise in good health, that deserves a real conversation, not an automatic decision. What to ask your doctor? Before discussing medication, can we go over my fall risk factors? And what's the actual reduction in fracture risk from this medication compared to a structured fall prevention program? If you've made it this far, and this is proving useful, type the number 4 in the comments. It's a simple way to show me you're here and following along. Exam number 5, asymptomatic carotid artery ultrasound screening. This is the one almost nobody discusses, and based on the research, it may be one of the most quietly impactful. A carotid artery ultrasound examines the major blood vessels in your neck that supply blood to your brain. The premise is straightforward. If a significant blockage is found, it can be surgically cleared to lower stroke risk. Sounds logical. The reality is far more complicated, and for symptom-free patients, considerably riskier than it appears. Here's the essential fact. The surgical procedure used to address a carotid blockage, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately following the operation. In older adults, particularly those with additional health conditions, that risk climbs even higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening for adults without symptoms no mini strokes, no vision disturbances, no neurological warning signs. Their findings concluded that for symptom-free individuals, the risk of surgical harm outweighs any potential benefit. Here's why. Many people over 70 have some level of narrowing in their carotid arteries. That narrowing has frequently existed for years, stable, silent, causing no issues. Screen for it routinely, and you'll find it, prompting a well-intentioned surgeon to recommend correcting it. But surgery to fix a blockage that was never producing symptoms can sometimes dislodge a small fragment of plaque that travels directly to the brain. I won't walk through a single case example for this one, because the documented outcomes are too serious to condense into one story. Medical literature repeatedly shows people entering a routine screening appointment and leaving on an entirely different life path than they anticipated, not because of the blockage itself, but because of the intervention that followed. What should you do instead? If you have no symptoms of stroke or TIA, no sudden vision changes, no facial drooping, no arm weakness, no sudden severe headache, routine carotid ultrasound generally isn't recommended. A far better investment lies in managing actual modifiable risk factors: high blood pressure, the leading driver of stroke, blood sugar control, quitting smoking, managing atrial fibrillation, and staying physically active. If you do experience any neurological symptoms, even ones that resolved quickly, seek evaluation immediately. That changes the entire picture. Practical framework, the 5-question protocol. I promised you something actionable, so here it is. Every time your doctor suggests a screening test, especially if you're over 70 and feeling fine, keep these 5 questions ready. Write them down, save them on your phone, bring them to every appointment. Question 1. What's the false positive rate for this test in people my age? This reveals how likely the test is to trigger unnecessary follow-up procedures, even when nothing is actually wrong. Question 2. If this test detects something, what are the realistic treatment options for someone my age and health status? This steers the conversation toward outcomes rather than just findings. Question 3. What's the procedural risk of any treatment we'd likely pursue? This is the question most people never consider asking. Every procedure carries risk, and you deserve to know it up front. Question 4. What happens if we monitor this instead of treating it? For many conditions detected in older adults, watchful waiting with regular monitoring is a legitimate, often superior choice. Question 5. What's the most effective non-invasive approach for this condition? Because very often, as with bone health, heart health, and stroke prevention, lifestyle changes and medication outperform procedural intervention with far less risk involved. Any good physician will welcome these questions and respect you more for asking them. And if your doctor brushes off these questions or makes you feel like a nuisance for raising them, that tells you something important about whether that doctor is truly the right fit for you. I want to leave you with this thought. There's a real difference between medicine that finds things and medicine that helps you truly live well. Past 70, the aim of your healthcare shouldn't be generating findings. It should be protecting and enhancing your quality of life, your independence, your energy, and your ability to do what genuinely matters to you. The finest physicians I've encountered understand that choosing to do less sometimes demands more wisdom than doing more. That recommending watchful waiting takes more courage than ordering another scan. You have every right to know what a test is actually looking for. You have every right to know what happens if something turns up. You have every right to ask whether a finding would even be treated, and whether that treatment would genuinely improve your life. Medicine has equipped us with remarkable tools, but tools only help when applied in the right context, at the right moment, for the right person. You are that person, and you deserve a healthcare experience built around your goals, your values, and your body, not around a checklist. If this video shifted how you think about your health after 70, please subscribe. I create content like this every week, practical, evidence-based, and honest, to help you take charge of your health during the years that matter most. And leave a comment below. Have you ever had a routine test lead somewhere unexpected? Your experience might be exactly what someone else needs to hear before their own next appointment. Take care of yourselves. I'll see you in the next one.